We haven't quite seen the mass in the head yet, have we? And this is a small bowel coming, yeah? That's the mass. You just saw the mass. There it is. And that's in the head, yeah? Do you guys understand what's happened here?
Should we measure it from this here as well?
Good. So, yeah, the mass is, this is not retroperitoneal mass. So, GOJ, 70% of examination you really should be able to do from station 1 GOJ. And what just Junaid has shown us elegantly here, sitting at the GOJ, portal vein is the divider. The top is the genu and the body of the pancreas, neck, and the below is the head. And this is the mass in the head of the pancreas. I don't think this is a retroperitoneal mass. And this will explain why this lady has dilated PD as well as CBD. Yeah? Very nice. But it's not going to be easy to biopsy from here, isn't it? So let's just have a look at the other end. Very nice. Sorry, what was the size of the mass?
So that was 3.9 into 4.
4 into 4 centimeter. Heterogeneous, hypoechoic. That's the aorta, that's right.
Do you want me to go ahead?
Gigi, please go ahead. Why not? You're doing so well. Why not? Just go to the GOJ and let's find it again. Has everyone able to see the mass in the head of the pancreas in the audience?
Yes.
Yes, okay, thank you. So at this point we think that this is not a retroperitoneal lymph node, we think this is a mass in the head of the pancreas which would explain proximal dilatation of the bile duct as well as pancreatic duct and the pancreatic atrophy distally.
वो खालिद ने अभी नहीं देखा मास.
Sorry?
Khalid has not seen the mass. He was checking his email.
Oh, okay. Yes, so you're now on. Yes, the portal vein, the PD, hepatic artery, and the bile duct at the top. Yeah, very nice. Yeah, so bile duct, you can see the double layered wall structure. Yeah. Pancreatic duct, portal vein, hepatic artery. Very nice. Okay. Yes. What a nice view of the pancreas. Doesn't matter. Don't worry. You've got really nice control. I'll keep it here. We should be able to do the sample from D1.
So from here, I should go.
Let's go to the. This is a maximum anti-clock.
Yeah.
Okay. Fine. So let's see if we can go to the clockwise now. And just follow the bile duct into the mass. That's a gallbladder. Everyone be able to see the stone? A large stone there. But no gallbladder wall thickness, so that's good. There's certainly some sludge. 2 stones. So it's not really uncommon. I'll always come back and re-intubate the D1. Honestly, it's not uncommon to do this, and that's absolutely fine. This mustn't. So we're in the stomach.
We are. I think I'm in the region.
Okay. That's the kidney. Yeah. There you are. You're getting some of the renal vessels you just saw. Yes, very nice. That's your gallbladder coming. So you probably are too much onto the anti-clockwise. So start going to the clockwise now. Yep, okay. So now you've gone past. So this is, you just started to see the uncinate of the pancreas because you're in. So let's get into the D2 mode and start coming back from there. Why not? So once you've gone there, I'd still get used to the small right wheel. It's always useful.
That's good.
And that's the mass we've just saw already. But that's okay. That's okay. Lovely. Very nice. Very nice. Okay. So you put the clock torque on and just pull it gently, 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 gently. Very nice. Keep the tip up. Beautiful. There you are. All right. Very nice. So suction on, and very slowly you now. So there are lymph nodes there. You just saw the lymph node, and this looks dark around. So this is a malignant lymph node. Yeah.
Bring it back to the ampulla.
That's okay. That's okay. Ampulla, you'll see EUS wise as well, but it's always good. Yeah, there it is. There it is. There it is. There. This is tracking up. Keep going up. I think it's right in that.
So that's the one.
Yes, yes, yes. Yes, yes, yes. Very nice. There it is. Okay, good. So once you've seen the ampulla, I'll go 1 centimeter forward, and then I want you to see the uncinate, because remember we want to make a distinction whether it's, we know it's pancreatic, but it's useful to see if there is a. So okay.
So that's the
Yeah, that's fine. That's the aorta. Yeah, keep it into that view. That's fine. That's fine. Very gently, keep slow movement. Swing your shoulders a little bit to the right and left. Very nice. Good scoop control. Very nice. Very nice. So when you see this, then here somewhere is the pancreatic head. And whenever something is on this side of the screen,
try to
you have to pull out. And when something is on this side of the screen, you have to push. Yeah? Very nice. So I've already started to see some uncinate there. This is all small bowel. This white that you see, these are just the subcutaneous fat amongst the duodenum. These are your mesenteric vessels, and they really just lay on the uncinate head. As soon as you see those, you know that the next structure going to come would be the pancreas from this side. Okay, it's a very nice tip control. Keep it there. Very slow, very gentle with the draw. Very nice. Very nice. So keeping it clockwise will show you uncinate. If you start coming gently, so that's another lymph node. Yep. Very nice. And now if you start doing anti-clockwise, you should see the PD first. Yeah. Yeah, very nice. Very nice. So the mass is coming here. Yeah, you just saw the mass there. There. Yeah. And actually the bile and all of a sudden you see the bile duct leading into it. Yeah. But we need to get it in a way where portal vein is not in there. Yes. So it's a head mass. I don't think there really is no fat plane between the two. And there are cysts in there as well. So this may well be, there may well be neuroendocrine. Can you see the cysts in between this? Yes, it may well be neuroendocrine. Okay, very nice. Okay, good. So let's see if we can have a look at from D1 again. So we established that from GOJ we won't be able to biopsy it. We won't be able to biopsy from the D2, station 3 as it were. So let's see in the D1.
फारूक, what's the plan? Mass बड़ा होता जा रहा है जैसे जैसे हम देखते जा रहे हैं इसको.
I know.
But
I know. I'm just looking for Junaid to find the spot. We have 3 minutes for trainer to take over. I think he's just doing so well.
3 hours or 3 minutes?
3 hours.
Okay.
Okay, good. So come back, come back, come back. Yep.
अस्सलाम वालेकुम फारूक, it's Mustafa here.
Hello, अस्सलाम वालेकुम.
कैसे हैं? ठीक हैं?
अल्हम्दुलिल्लाह.
अच्छा, good. I think वो जुनेद भी कह रहे हैं कि आप स्कोप कब लेंगे मुझसे?
ओए ले लांगे यार.
वो हमें इधर से आई
सर अब मुझे जो मेरे पीछे एडमिनिस्ट्रेटर खड़े हैं उन्होंने कहा आपने 12:30 बजे से पहले स्कोप नहीं लेना.
अच्छा, उनको आप इधर भेज देना ज़रा, फिर आप पकड़ लीजिएगा.
Unable to trace the CVD.
Right, let me have a look. Let's see what this is. Lock में? Is it locked? It's all on. Let's just start from the.
Middle से 22 की?
Hmm?
Middle.
22 gauge. Yep. Yeah. So this is the window that we're getting from the GeoJ. Yeah. So we should be able to take a sample from there. So that's the GeoJ that you can take the sample from. इनका head थोड़ा सा ली तरफ करें please. It feel like I'm running after her, which should not be the case. So that's the safe window, I think. We should be able to try that, yeah? So let me just take one sample from here. So my technique is more or less the same as Mustafa has already shown us. So we're using 22 gauge Acquire F&B needle. So she's retching at this point. It'd be helpful अगर हम इनको थोड़ा सा बेहतर sedate कर लें.
Do you think there is a vessel you are just compressing that in your way?
So
You're just compressing the vessel in there. It's a big vessel.
At this point, but I think there is a window that I'll show you. What do you think?
No, I think you're just compressing it. The vessel is there. And
Yeah? Okay.
where are you? Which
GeoJ.
D2?
GeoJ.
Oh, yeah. Okay. I think. Well, how about?
We'll have a look from there
do
as well.
see that. It's. Is there any other area you can see it from?
Yeah. Let's try it.
Yeah, I think there is a vessel is just getting compressed with your transducer.
I think I was clear of the vessel, but why don't we have a better look from another? That's fine.
Yeah, I think you'll see it from D2, D3 because it's an unsnit type of region.
It is
Yeah,
far
so
down.
I think, though honestly I think you could get away with it from where you were, but
No, but why not? Why not?
why not
Like,
avoid the vessel
Well,
if
of
you
course,
can?
of
And I
course.
think that was the confluence that we were seeing there.
yeah, why not? So let's just go into the. Again, a large full better. So here you definitely have the vessel at the top. So this is D1 now. So no clear there. Let's just go into D2 and see if we have a. Okay, so that's the infinite coming there. So that's the mass, but it's still a bit far for our liking. Let's see if we can get it there. Oh, sorry.
I think maybe try from here, pulling the scope back a little bit. You should be able to get the edge up.
Yeah. No,
Yeah.
true. So
I think at least there is no major vessel there.
the difficulty here is that I'm right. The scope is at 52, 53 really. So it's just the very last pull that I'm having to do. So this uncinate type lesions are really.
Yeah, they could be problematic. It looks like a lot of pancreatic tissue in between to get to that.
True. Let me just try.
Whatever you feel comfortable. If you want to do from the other, that should be
No,
fine.
that's okay. We can certainly try, but the difficulty here is, so that might be a bit more.
Yeah. This is if you can, stabilize that. That's really good.
So I think I probably, but at this point, I have full big wheel down towards me. So I'm going to have to relax it a little to have a needle out. जुनैद ये बड़ा चैलेंजिंग होगा आपके लिए unfortunately. So let me just do this one.
Yeah.
Okay. Now we've lost it, haven't we? मैंने आपको बताऊंगा जब आपको स्कोप पकड़ना होगा, ठीक है? फिर आप मुझे हेल्प करना. अभी तो I think at this point we are back in the neutral.
Yeah, you guys can see that these uncinate process mass could be challenging, even though the mass is quite big, but these could be challenging. If you try to do it from D2, sometimes the ducts come in the way as well. So that's the challenge he's having. He's trying to avoid those ducts if possible. And here, I think.
So this is the D1.
Yeah.
But it's relatively unstable. I'll see if I can.
Maybe if you want to go here, that should.
True.
Yeah.
True. So that's the, if everyone can see this, where is the ABC?
Right there.
Yep.
And sometimes you have to pick your battle. Like you want to go, like is there a big vessel you want to avoid? Or it's you maybe be able to get around the duct itself. Is that possible? Here it looks like, I think there is a little bit maybe some pancreatic tissue he may have to go through, but I think this is probably the best and the safest place if the scope could be stabilized. I don't know if it's the patient breathing. which is causing an issue, or
it's a very unstable position of the mass ना तो वो जब retch करेगा तो it will move my scope quite significant. Oh, you see?
yeah, I think it's the breathing, mostly heavy
Yeah.
breathing.
So whenever patient retches, as you see, the whole dynamics changes there.
And also, it's okay if it's like an unstable position. If you think, if your tech holds it at the scope and that's gonna stabilize it for you better, just do that. And there's no shame or hesitancy in asking somebody to hold the scope.
So I think this is probably the best shot we're going to get.
Yeah, I think so. This is the more
आप scope पकड़ लो यहाँ
like
पे, please.
seems like the least harmful area.
Yep, yep. So again, we'll just push it a bit there.
Yeah. Yeah.
Okay. So push it back in. And now slow pull for me, please. Chalo. Thank you. So it feels very soft.
So the capillary technique, which we call, we don't use much, but if you
निकाल
can,
लीजिए।
if you want to use it, there has to be a
और suction लगा दो मुझे,
coordination.
please.
The goal is to create a vacuum there. So when the needle goes in, the stylus should be getting pulled out. It's not no point of
Thank you.
pulling the
Thank you.
stylus when the needle is coming back.
So the more I go
creating
there, I get a better. I might miss the needle direction a little, but again, we're just going from.
So he's trying to change the track of every other pass. You may not appreciate that, but with the wheels and sometimes with the elevator, he's trying to change the track with the after every 2-3 back and forth movements.
Sorry, तो मेरा अपना ही हाथ है। जान के ऐसा दिखा ना, हंसिया रहे देखिए। चलो, thank you. Thank you. So we'll stay in this position. We'll wait from the Rose team to tell us if there are any cells.
No, sheet is not going to do anything except to push the your lumen wall away from you, and you don't want to push the seam sheet too much because the needle puncture closes very easily. If sheet punctures the wall, that could be more problematic.
Is
So
okay?
it's just like you have to do it, keeping in mind that every single needle when it comes out from 22 is an 8 centimeter.
हमने तो इससे काफी sick patients look after किया है।
Cover that much area.
What we have, remember we had, we had experience of. You got the cells? Very nice. So we've got good core, we've got good cells. I'm quite comfortable with one pass. We got a good core. Anybody in the audience want us to try again?
Yeah, I think if you're comfortable, that's good enough.
Good.
Fine.
Yeah.
I will do it.
We got good cells.
Can you ask them to just show the sample, please?
Cells हैं वसी? देखें, I don't pull it out, so they just.
Can they just ask them to just show us the sample, please?
Sample दिखा दें please. All right, just wait a minute. जी, वो मैं I'm waiting for Wasim to tell us.
Pancreatic lesion with vascular involvement. How would you differentiate between that and
So cystic, this is hyper echo. This could be next. And if you have a dilated duct, he doesn't have a raised LFT. So the behavior net is a bit spongy. You still get some flow of the bile.
You should be able to see the mass.
But make no mistake, stage 3 net is equally bad as Newcastle. So, yeah.
You'll be able to see whether the vessel is actually going to
So this is, what you see here is right the portal vein. I think,
or actually
at this point, I can't really, I think this is averting the portal vein. I definitely think it is.
इसमें तो कोई ऐसा
I definitely think it is. ये कैमरे पे दिखाएं please. Can everyone look at Wasim's hand? Cameraman को बुलाएं please.
थोड़ा करीब कर देंगे इसको फोकस करेंगे वसीम की टेस्ट ट्यूब जो नजर आ रही है प्लीज
सब नहीं कर रहे
शहजाद यू आर ओके फारूक
Oh, it looks gorgeous. It looks gorgeous. आप लोग एक
oh there's lots of white tissue there we can see it from a distance fine yeah okay good
So if
that's good sample well done Farooq
हाँ,
that-
ले लो, अगर cell नजर आ रही है,
did
तो
everybody appreciate the white tissues right जब आप करोगे
Okay. I think I'm happy if anyone in the audience wants us to go again. I don't think there's any need, but I'm happy to go back if anyone in the panel feels we should. Yeah, no. नहीं, मेरे ख्याल से दो वाइट देख लिया ना मैंने उसमें कुछ. Now I want you to withdraw.
there's no biliary obstruction here Farooq
Sadhvi, bile duct is dilated, but it's not massively. It's about 9, and certainly not. She's not jaundiced either.
okay
0.4.
Huh?
She's a bilirubin of 0.4.
Bilirubin of 0.4, I'm told. Thank you. So that's the bile duct right on the top, if you guys can see on that screen. And that's the pancreatic duct there. And Junaid will just show you how the bile duct will walk into this mass. keep going to the clock. You were doing fine, Keep going. There you are. Yeah, can you even see that? But also see that it's not completely obstructing the bile duct. Can you see that, everyone? Go back to the anti-clockwise, please. So that's the mass, that's the duct, and he's just going to walk us through it very slightly, clockwise. So it walks in, and then it just goes right. Let me just show you the arrow. Go again. So this is the bile duct walking in. This is the mass. It's very slight, slowly clockwise, Junaid, please. And there it goes past it into here. So that's why she's not really jaundiced, because it's not. So what Saad Bhai asked, a very pertinent thing, and I think we should make that assessment always. So it's not blocking it, but yes, it's clearly pressing on it. Yes. And in fact, exactly. And it goes back and then comes into this mass here, which then becomes dilated. चलिए, अब इसको बस withdraw करो. Thank you. I'll do you know you can do the report, huh? Averting the portal vein, compressing on the bile duct, but not obstructing it. It's always very useful to see. Today, happy? Any question? Any 67? चलिए, good. Thank you. On the non comes that, तुझे कॉफी भी नहीं पी
ऐसे थोड़ी ना
ये लास्ट केस था इसलिए करवाया
ऐसे थोड़ी ना
कोई भी कर सकता सी
ऐसे थोड़ी होता कि कॉफी भी ठंडी करा दे आदमी के ऐसे नहीं होता
बच्चे की जान लोगे आपने मुझे वो दिखानी है जो आप लीड्स कह रहे थे उसकी स्ट्रिंक्रोटमी वाली मशीन की नहीं आप कह रहे थे वो मुझे उसकी बताओ ताकि हम आप जाके उसको प्रिपेयर कर लें
अच्छा इफ्तिखार में बुला लो
ठीक है
मैं
कर लेते वो कोई
भाई काम करो यार तुम लोग गपशप कर रहे हो
इफ्तिखार भाई को करने बताएं
अच्छा मतलब why did we incubate it? इसकी मैलम पट्टी भी ज़्यादा हो गई। ठीक, हाँ ठीक। इसका ये बाजू में पेन ना हो जाए, बाजू में ये दर्द ना हो जाए, इसका हाथ मोड़ा ना, देख लीजिएगा। हाँ ठीक है, अगर आप कंफर्टेबल हैं तो चलें जी, गुड। सो ये डायरेक्ट सीधा आगे चलेगा। थोड़ा सा वापस खींचे, जियो जे पर आ जाएं, ठीक है। मुझे ज़रा इधर आने देंगे प्लीज़। हाँ आप इधर आ जाएं बेशक। हाँ चलें, वो ठीक है जी, सक्शन कर लें आप। अच्छा इसमें ऑटो का बटन होता है, जो ऑटो फोकसिंग का, वो नहीं होता, ठीक है। ठीक है, excellent. Okay, so yeah, but as soon as you put the scope in at the GOJ, you will see the liver, left lobe of the liver. So you can assess that. So I'll just wanted to reduce a bit of the gain and see if we can focus it. Sorry.
Yes.
Okay, excellent. Okay, so excellent. So large vessels that you can see in the liver, usually, can you see the IVC? It's coming in view. Excellent. So Khalid Bhai will be discussing the segments of the liver in a little while. So if you keep on doing the clockwise motion, and the idea is to see if you can find the aorta, which is the home station. So जिस तरह बच्चा गुम जाता है ना तो सीधा घर आता है, तो ये जो घर है ना GOJ के ऊपर, वो आपका aorta है। तो कहीं भी आप if you get lost, so you just need to run back to the aorta, and that will give you the confidence to do a more of a dynamic study. So okay, so apply a bit of suction. आपके जो little wheel है, that इसमें lock तो नहीं है ना little wheel, देखिएगा। No, okay, that's fine. Okay, excellent. So so at what level are you? I think you may need to just pull back slightly. Just pull back slightly. Yeah, excellent. Okay, now. Okay, apply suction there. Yeah. Okay, keep on going. Keep on going. So use it dynamically, freely you can use, just use it dynamically on this side and then on the other side, so that you can, you're just trying to find. So now you know that you are quite up because you can see the heart. So you can push it down slightly, and then now you can turn it around just clockwise motion, and you should be able to go around that bit. So, so see if you can find the aorta again. So you are on the liver, excellent. So go back. Have you turned around 360? I think you just go back all the way. Okay, excellent. Sorry. Excellent. Okay, so I think you're getting the mass thing up there, but we are just we're going to ignore that for now. We'll just look at the anatomy first, and then we'll come to that bit. Okay. So just use the liver, I guess. So now do a clockwise rotation. So you want to find the aorta, yeah? That will be your home base, yeah? You're getting good views of the liver. Excellent. Excellent. So keep on going until you get good views of the aorta. So I think you just slipped beyond it. Just there, yeah, that's it. But it's quite horizontal, isn't it? So push the scope in slightly there at this level. So turn it around, clockwise torque. So it's very stiff, isn't it? How now that's it. That's the aorta, but you're quite high up, so you just need to push it down, push the scope down, and I think you're pushing on it with the wheel. See if you can move the big wheel away from it, and that's why you're not getting a good image. So keep it in the neutral position, the wheels. Okay, so we do slip through the, yeah, excellent, that's the aorta, but it's quite, horizontal, which probably means you're quite high up, or you're pushing it with the wheels. So put the wheels in the neutral position, and then see if you can push the scope gently in, yeah? So you're quite high up, I think, yeah? Okay, so just let me have a look. I think we are a bit lost here. Let's just see if I'm just going to take away the wheel pressure that you had and just keep it under GOJ and just see if we can just see. So that's the aorta. So here we are. So I think what you were probably doing is that the wheels were bent, and can you see that the aorta is coming up? So just try to see if you can, simulate that again. Okay, so have a look at the aorta. So just clockwise torque. Clockwise torque, yeah, excellent. So that's the aorta coming up, okay? So he is a very large chap as well, So see now pull back on the aorta. You just want to get the first vessel. So okay, that's fine. So we now know that we are roughly in the crux of the diaphragm, you can see there. So now we need to just find the first vessel that comes off it. So it was coming a bit on view, so you can put some Doppler on it if you wish, just to see, that. So we know that you're on a vessel. So yeah, keep on pushing the scope in gently. Yeah, excellent, excellent. So you are roughly, yeah, you can see the celiac axis coming off there, isn't it? That's the first vessel that seems to be coming off. So if you rotate it left and right, sometimes the celiac axis doesn't come off from the front anteriorly, it can come off from the sides as well. And therefore it's better to do a dynamic, view. You move it left and right until you can see where it is coming from. The SMA just came into view in the bottom. You can see that. Okay. So the pancreas is coming up here. So if you put the aorta in the center and keep on pushing the scope in, you should be able to reach the pancreas, okay? So keep the aorta in view. Excellent. And now push. You can see the mass is coming up there as well, the thickening of the lining. So we will come to that in a moment, but we're just first seeing the pancreas if we can. Yeah, so you saw the splenic vessel that just, I think it just whizzed past you. Okay, just go a bit back on the clockwise, anti-clockwise, go a bit anti-clockwise, yeah, excellent. And see if you can push the scope in slightly here. It seems to be bending, isn't it, at this point? Yeah. Pull back the scope, make it straight. Yeah, so that's the left, the adrenal gland you can see, but so those are good views of that, yeah. Excellent. So your aorta seems to be quite horizontal. See if you can get it a bit more straighter. Uncha bole? Acha. Sorry, I've been told to speak a bit louder. So we're just trying to get the aorta in position. We had a look at the left adrenal as well. So Dr. Afan can demonstrate that again if you just put the scope in a bit. Yeah. Excellent. So I think you probably are using the wheels. That's why the position is changing. It may sometimes happens as well if you're in a hernia. So pull the scope back a bit again. Yeah, try. Excellent. So we're getting a better position of the aorta. Pull the scope back. Excellent. Yeah, and move a bit of a dynamic motion. So you're now on the liver, aren't you? So just move that. That's the splenic artery that's coming up. Try to bring that in the center. So pull the scope back. So if you pull the scope back, it should come down here. Tip down also helps. So move the big wheel down away from you. Can you see that? It's just dropped back down. Excellent. So just pull the scope back slightly and see if you can now follow these vessels, yeah? So the pancreas tissue is up on the top. So again, the seagull sign that you're bringing up, yeah? Okay, let me have a look. We're not getting very good images, are we, here? So just getting back to the aorta, and then I'm just seeing if there's probably a bit of hernia there. That's why your scope is not moving. Your scope tip was, I think, stuck in a hernia. So that is why when you were trying to push it in, it was not going to. So okay, you can take it now again. But that's another learning point, that if you are trying to push and the scope is not going in, just make sure you're not in a hernia at that. Suck all the air out. Yeah, excellent. And now just move some movements on the clockwise and anti-clockwise, and you will see that you are. So that's the splenic vein that you can see, probably. Yeah, see if you can. So that's going down into the portal vein. The images are not very great, are they? See if you can follow it towards the tail. So clockwise rotation. Seem to be stuck into that hernia again. Just show me. I think it's just at the edge. Let me just see. Where are we? So I'll just have a quick look at why are we struggling here. So that's the splenic vein. You can see that. And then I'll just follow that to the. So that we're getting good views of the pancreas here. That's the left kidney, and I'm just going to follow that down into the spleen. Okay, so I want that movement, if you can just demonstrate that. So if you just hold that there. So can we enlarge this? How do we enlarge this? Can we make it bigger? Make it bigger?
Okay. एंडोस्कोपी
नहीं this big. बड़ा करना,
Okay.
zoom कर दें इसको.
अच्छा आप उसकी
zoom
डेप्थ
करें?
अच्छा
हाँ.
सॉरी
हाँ बस ठीक है, that's fine. And let's put the flow on it. Just bring those two vessels in between. Yeah, excellent. And if you are not sure which is the artery or the vein, you can put power Doppler on one of them. Okay, they are not seeing at the moment. So when you get them back in vision, you will see. So do a clockwise torque now at that position. Yeah, I think that's no, I think, yeah, probably just move up on this structure. Yeah, so push it down. You can bring that structure inside. I think, guys, we are struggling because of the hiatus hernia, because the tip seems to get stuck there. Yeah, but that's good view. So you know that it is a vessel. You can put some Doppler on it. And if you want to see whether it's an artery or a vein, you can put some power Doppler on it and see, what does it look like. It usually should say update. Give it an update, please. So that's the splenic artery you've got, okay? So you know that now, that it is an arterial structure. The portal vein is, the splenic vein is probably down there. That's the pancreatic tissue. Now see if you can trace that all the way to the hilum. Do a clockwise torque. Now these vessels are a bit tortuous, so you will see that you'll be moving up and down, and they may be coming in and out of view. But if you keep this in the center, yeah, excellent, and now keep on doing the clockwise torque, you should be able to reach the spleen. And don't put too much force. If you feel that the scope tip is getting stuck in the hernia, then don't push too much, okay? Yeah, so you've got the kidney coming in view, the left kidney is coming in view, so follow this vessel, yeah, excellent. So you've reached the tail bit now. Now see if you can trace the vessels all the way to the hilum. Yeah, excellent. So you get into the hilum, excellent. So the splenic artery is on the top, the splenic vein is below here, and you're reaching the splenic hilum. If you continue going, you can take it all the way into the hilum of the spleen, okay? Excellent. Now see if you can trace it back all the way. So the splenic vein is in the bottom. It's a bit compressed, can you see? So if you take away the pressure on the vessel, can you see there how it opened up because of the pressure? So that's the splenic vein. So you just bring it, keep on bringing up. That's the splenic artery. It's changing its course, yeah? Yeah, excellent. So this vessel will start to go up now. So pull the scope back slightly, move the big wheel away slightly from you. Excellent. Pull the scope slightly back, so that relaxes all the structures. Yeah. Now keep on pulling the scope back. Oh, so it seems to be, yeah, excellent, excellent. Keep on pulling it back. Okay, so that was the part of the aorta that you were seeing again. Okay, let's see if you can go to the lesion again now. Now go at the GOJ. So what you would see is that next to the transducer, you will see thickening of the mucosa, okay? So you can see it first endoscopically if you wish, but it seems to be coming up now. So see if you can find it endoscopically, and then you can pull back so that you know exactly where the GOJ is and where your lesion is. Yeah, excellent. So you're a bit up, aren't you, on that? You can go into the stomach. Yeah. Yeah. Okay, so can you see that there was a bit of scope trauma there because of us? Yeah. So I think you're coming up with that lesion here. So now push the scope in slightly. Okay, let me just have another look. I think this hernia is causing you a bit of a tough time. So the thickening seems to be somewhere around this bit. Can you see that? You can see that area of thickening that is coming up. Yeah, and the layers, can you see the layers? You can make out the layers as well there, yeah, of the esophagus and the GOJ junction, you see. So the outermost, the hypoechoic is the serosa or the adventitia. That's quite bright, right? Then the furthest away hypoechoic area is the muscularis. The middle hypoechoic area is the submucosa. The closer one, is the smaller muscle layer, and then you've got the superficial layer as well. But certainly there seems to be a mass there. So let's see if we can go right to the edge.
फारूक थोड़ी सी सॉरी शहजाद की आवाज़ सही नहीं आ रही बेटा थोड़ा सा आवाज़ कर देंगे आपका फॉल्ट नहीं है आई थिंक मे बी देव टर्न डाउन द
Can you hear me now?
Yeah, because you can see the layers very nicely,
yes.
So I thought it would be a good case
so, yeah, we just can see the layers here. We're just discussing. So we're just discussing that the muscle layers appear hypoechoic. So the distal one is the muscularis propria, which is thickened. The outermost is the serosa or the adventitia layer. So you can see them quite nicely. The mass is, this thickening seems to be quite superficial. It seems to be, not deep at all.
Yeah, so you can see both the muscle layers.
Yes, you can see both the muscles very clearly. Actually, you can see even the submucosal layer. Yeah. It seems to be not broken. So it seems to be very superficial. Let's put the Doppler on it just to see whether there's any blood
So
vessels
this was an
around.
incidental finding?
Yes, so on endoscopy, they found that...
they found a swelling and so they did a scan as well.
So it's not vascular in any way. I mean, just a few blood vessels, but nothing exciting. So we will biopsy it to see the nature of it, but any comments from the group? What do they think this is? Because it seems to be very superficial.
Shahzad, does it look like all solid to you, or what is that in that? Is that a tissue, or do you think there could be like thick debris in there?
I don't think it is cystic. It does look solid to me.
Okay.
I don't.
Yeah, I think the only reason I was sitting is like you see the walls all around it. You see that?
Yeah.
So the duplication cyst with a very thick debris can look like that. So just want to make sure that's not the case.
Yeah. Firstly, it is further down. Usual
It
duplication
is
cyst.
a little bit more hypoechoic inside than the duplication cyst would look like. Definitely. So it's a
So we will take some samples from it, and then we can take things from there. Okay. So can we have an 22 FNB? Yes. Yeah. Okay. Excellent. And once we've done the sample, we'll go to D1 then, Afan, and then you can have a
and
go
it's
there.
okay to stick a needle too, even if you think like when there's a question, you can do FNA even for the duplication cyst. And if you see all debris, thick junk, and then no major cells under the microscope, then likely it's a duplication. And duplication cyst can have a really, really thick debris.
So we just open it and just push the needle in. But the key thing here is to, can you just attach it? Just hold it. So hold this. So push it in gently. So this is the key thing. If it's not going in, just stop there. If you find it a bit difficult because you can damage the scope, at that point just pull it back, make sure that the bridge is away, the scope wheels are in between, and then you can try. If it's still struggling, then just stop. Can you just push it gently? And you'll see it's struggling there. Stop there then. So I'm going to just straighten the wheel, and now try it again. It's gone in very easily, okay? So that's a key point, because sometimes if the tip is moving away, then the needle may be actually poking into the channel. So you're safe. The other thing I have to do is to make safe is to open the little wheel on the bottom, and I just push it out, push the sheath out. Can you see that? You can see it on the EUS. The sheath is out. So once I've confirmed that the sheath is out, then I can lock it in place. Now I'm pretty good. I know that the needle is not going to damage the the scope in any way. Okay, so this is the area that of interest that we were planning to biopsy. So
Sheath out, okay, you will lock it.
yes, yes, you can lock it. Okay, so let's just see if we can take a biopsy of this. So again, the tip is blunt when the whole stylet is out, because the stylet actually is poking out by another couple of millimeters or so. So if you want to make it sharp, you just pull it gently, and it's out now, the stylet. So that makes the needle quite sharp. So once you've done all of that, I'll just put the last bit Doppler in. Doppler will just put, just before you put the needle in, it's better to just put the Doppler. Yeah, okay, needle back. So, and then you've got a good view. So I'll just jab it in. So we are in, okay. So can we start the slope? So we'll start slowly and just try it. We'll start the slope. So it's nice and soft, this lesion. So it's very soft. And it is moving along with me poking the needle. Yeah, continue with the slow pull.
I think you keep coming out of it. So
Yeah. Yeah, keep on going, keep on going. So we'll just try to see if we can, fan it a bit. Yeah, excellent. So we'll try to get the sample without the first, and then we'll see. Yeah. मैं आपको करता हूँ measure. Okay. Yeah, excellent. That's fine. That's fine. I think we got it. Yeah, you can pull it out. So yeah. So yeah. So from my side, it looks epithelial or superficial. It doesn't look deep. And then
duplication cyst, you want to put a section on just to make sure you don't have to go back in there and not get it.
Okay, so I'll just measure it if I can. Can you just measure it, please?
Covered by all 4 layers.
Can you pause it and then measure it? Please, and then measure it.
A submucosal tumor,
यहाँ से नहीं
which is
करें.
only attached in one area.
So it has to be measured. Enter किधर है?
That can look like this too, like the layers are, except one area.
So 17 millimeters, so 1.7. Okay, and then under side, yeah. नहीं, इसको वापस ही करना है. दोबारा measurement लगाएं. दूसरों को भेजें, उनको ज़्यादा मुझे लगता है कि एंट्री है. हाँ. $23 millimeters. हाँ 17 into 23 millimeter, ठीक है ना? Okay. Okay.
1.7 centimeter.
Yeah,
17.
17 millimeter. So the layers are, इसको magnify कीजिएगा. Excellent. और magnify करें. ठीक है. और इसकी frequency बढ़ा सकते हैं या नहीं?
If you look at the wall layers all around that,
कहाँ लिखी हुई frequency
you
इसकी?
clearly see all the layers.
अगर नहीं पता तो छोड़
Duplication
दें.
says
ना
is
ना
an
उस पर ना
other
छोड़ें.
lumen basically.
If you're not sure, then don't do it.
Thick
Yeah.
debris. So if you look at this, you can see even at the bottom all those wall layers on the left side all around except one area on the top. So not that just a leomyoma or some position can present like that.
See the layers very nicely. Aya? Yeah. Okay. Let's try again. So we'll try suction this time. ठीक है?
So there are areas of
मैंने started के साथ ही started off करके आपको section
हाँ.
very high
किस जगह? मैं देख के बताता हूँ. एक मिनट मैं देख कर बताता हूँ आपको. Okay. So the key thing was that when I had the, okay, Doppler please. Okay, excellent. Doppler can go off, and then if you just remove the needle, we won't do a slow pull this time. We'll do proper suction.
Was there
Yeah.
a tissue there or no?
Sorry?
Was there a tissue?
No, we didn't get any tissue.
So do you want to use a suction on that?
That's right. We just got the suction ready. Yeah. Was there any material, any sort of material, or nothing came out? Yeah. Okay.
Was there
Okay.
any
Suction, yeah.
material? Nothing
No,
there.
no, nothing there. So we're going to try again. This, it seems very soft as well.
Yeah, that's
Yeah,
what
just hold it. So I'll just do some fanning of it if I can.
Yep.
So just so that we can get some
So,
variety of the sample in different areas. Yeah. So seem to have sampled quite a bit. I'll just take it out. Fingers crossed. Let's hope. चाय पिलाऊंगा यार.
क्या
Usually when I encourage my nurses with a cup of tea, the sample comes. So let's see. हाँ? वही ना. और बिस्किट का कह दें तो प्रोसीजर से पहले ही सैंपल आ जाता है. So do you want to have a look around the cyst? So the key thing, as Dr. Mustafa was saying, it's a dynamic scan. So just don't be worried about losing the bit. So just move it around left and right, and you will see, the more movement you do, very gentle movements, but play around of it. So go from one side of it to the other side, and then you should be able to go all the way to the other side. Try to keep it in the center. That will give you some scope control, so you will know which way we're going, and then you can appreciate the layers here. And if you go a bit clockwise, you will have a better look. Yeah, you can see those layers there. Can you see them? Yeah. How are we doing with the? Okay. ये क्या वो material tissue लग रहा है या वो लग रहा है? Tissue लग रहा है. Okay. Come. Okay. So heterogeneous. Yeah. So Khalid bhai, we've got some samples. We'll just do one more pass. If you want to make your way for the liver segments, if you come to our room. Excellent. So we'll do one more pass. Okay. So
Khalid bhai is on his way.
yeah, I don't think he wanted to come. Oh, excellent. So we've got a 2 centimeter core, I think. Can we have a look at that? Just let's see if we do need enough, or do you seem to have. Yeah, single core, we've got a decent sample. I know how it's a nice tissue sample, yeah. I think that should be enough. Yeah, yeah, that's a good core, isn't it? Yeah, up and down. Simple. अच्छा सवाल है. We seem to have a good core, decent core on this time, so probably not. Let's just not. There's no. It won't add anything. We've got cells as well, and we seem to have a core as well. Do you want to quickly go into D1? Okay. Sure. Let's show Khalid. Yeah. Okay. Huh? Okay. Within red cores है ना? It's.
लेकिन वो तो सारा जंक ही लग रहा है.
हाँ, लेकिन वो दिखाना जरा वसीम कोर.
किधर दिखाते तो जरा.
टिश्यू वाली बोतल आपके पास?
वो even like that.
जेली टाइप का नहीं था.
जेली टाइप का
नहीं था. वो जो मैं ये देखो मेरे तो काफी लंबी कोर.
लाइट ऑन करना.
लाइट ऑन करना.
आयशा
मोस्टली क्लॉथ है और एक साइड पे थोड़ा सा. इसमें कुछ है?
एक और ले लें क्या?
हाँ
मैं दिखा रहा हूँ.
हाँ दिखा दो.
स्केलिंग कर लीजिए.
ये आप
नहीं मुझे सिर्फ ये है कि वो
डुप्लीकेशन
सिस्टम.
लेकिन उसके लिए यूजुअली वाइटिश सा मटेरियल आता है ना.
वाइट यूजुअली मटेरियल आता है. ये है कि एक दो दफ़ा अगर आप कर दें तो वो ये आता है. दैट लुक्स मोर लाइक अ डुप्लीकेशन सिस्टम. Yeah, the way it is all around like irregular, that's a duplication system.
Okay.
Usually.
Afan, pull your scope back a bit so we can see the proximal side of the lesion. Now spin around.
दे देना एक बार.
Spin. Other way. Keep spinning. Yeah. जहाँ नीचे में. और खींचें थोड़ा इसको. Scope को और खींचें. और spin करें. Okay, go the other way now. Just slowly go the other way.
On the FNA? Okay.
Right there. You're looking at the that's right. Push forward
साइटोलॉजी
a
उनसे
tiny
क्या
bit.
इसको लगा. So we'll just project the slides on the screen. We seem to have some cells.
Go clockwise a tiny bit.
आपने size
Okay. Now go counterclockwise.
It's still could be just this is the layer, like could be a wall layer.
Pull back a tiny bit.
Understand.
Yeah, तो वो भी हो सकता है.
And go clockwise.
Okay.
Still वो जो fluid है ना
हाँ.
उसमें move हो गया.
And go
But CT
counter.
should pick it up, isn't it? MR, हाँ. हाँ.
Keep going counter. Keep going counter. Other way. Other way. थोड़ा सा pull करें. Shazad, can you just show us
Yep.
the layers of the stomach
Layers
right
of the
proximal to the
gastric,
lesion, like on the proximal extent of the lesion, right there.
Okay.
So यहाँ पे we would like to see the splaying of the layers if possible.
So I'm just pulling the scope back now,
Going
gently.
and right there, just play around, like just see if we can separate them.
क्या कह रही हैं?
So
Okay.
what did
They
you
were
get
just
on the
wanting to see
slide?
the proximal area of it.
Yeah, because that would give us a real idea कि it's
It
attached to
seems
the.
to.
There's the piece.
At this level.
What's our specimen looking like?
So एक
ये लीजिएगा हाँ.
ये मुझे mic दे दें.
Okay. ये उतार दें. सर सर को दिखा दें. एक यहाँ से नहीं खोल लेना. यहाँ से बोल लें इस वक्त जब तक.
So on specimen, there are some smooth muscle cells in there, but have to be careful interpreting those. It still could be as a really a cyst or a leiomyoma, but sometimes you do see these smooth muscle cells. They may be coming from the wall itself when you puncture it. So I think, can you put that on there? इसको ज़रा और clear कर दो. हाँ. और क्लियर करो और उधर डाल दो
Can
इसके
we
ऊपर.
project the slides, please, on the screen? So there are some cells. You see those spindle cells in there? Possibly still could be either of those. I think this is just going to require a staining of the tissue to determine that. Here, if you, I'm going to try to show you like where the muscularis propria enters in there. Like right here, the muscularis propria, I don't know if it's
Right there.
right there. I'm going to
Right
freeze
there,
it. Yep.
Yeah.
So right here, if you look at that, muscularis is coming down. So, and there are no, in this area, there are no distinction of wall layers. You see all the layers here, but this is protruding into the stomach's lumen itself. So you are expected to see the layers here. So is it arising from muscularis propria here and really is a stromal tumor? Very possible.
I think so. If you look at
so right here now it's looking like there is no wall layers right here. This is muscularis propria right here. Nothing is arising from that. So it likely is very possible that it is a stromal tumor.
yeah, and the slides are very suggestive of a stromal tumor.
Slides are very suggestive of
Yeah,
that.
with all
Yep.
that fibrous tissue. So I think
इसकी पिक्चर ले लो जरा यहाँ पे.
Picture say please.
I think that's one of the key things with submucosal lesions, that you want to see where the lesion is and like where the entry point of the lesion is from the normal wall.
You're right
Because
there. You
right
see
there,
that?
that's where you want to see the separation of the layers to figure out which layer it's coming off of.
Right there. So
And you can do that at the proximal extent or the distal extent, depending on the where the scope lines up best.
and but the point is, like, yeah, you have to keep your mind open
Yes.
about any possibility, any type of this lesion.
Yeah.
So,
Yeah.
okay, good.
Yeah, it looks like a more like just based on that view.
So I'll try to show the liver segments in there. As you guys, everybody knows that there are 8 different segments. First of all, there's a right liver, left liver. Right, then right is right anterior, right posterior, and then the left lobe. Left lobe is like a caudate lobe, and then there's segment 2, 3, 4, and then there's a right. 2/3 of the liver is on the right side, right anterior, right posterior. Who is going to tell me right anterior, which segments are those among the trainees? And right posterior, which segments are those?
5, 6, 7, 8. Madam light.
No, that's 5, 6, 7, 8. Yes, that's a right lobe. What is a right anterior?
Right interior 5, 6.
Okay. Anybody else?
We have complete silence.
Okay. So right anterior would be segment 5 and segment 8, and right posterior would be segment 6 and segment 7. So majority of the liver, especially the left lobe of the liver, ये इनको ज़रा ठीक है. The majority of the like left lobe of the liver you can see from the stomach. A good portion segment 8 and segment 7 you are able to see from the stomach as well. Right lobe of the liver completely, however, you can see from the duodenal bulb. That would be both right anterior, right posterior. Keeping in mind the penetration, the good penetration of the these ultrasonic waves is up to 4 or 6 centimeter. So you may not be able to scan the whole liver completely, but pretty much every segment you can see a good portion of that. You can see the whole segment 2, you can see the whole segment 3, whole segment 4, to some extent pretty much all the segment 8 as well, segment 5, 6, like majority of the liver you should be able to see that. So here the way we'll start with the एक मिनट मुझे वो दिखा देना endoscopic view, ठीक है? तो ये ठीक. So this is a little bit blood from the FNA. So I'll blame Shahzad and Afan for that. Anyway, no, this is nothing. It's just FNA. So here the way I always tell is like from the GE junction, go towards the opposite wall of the stomach, and then you use the suction. That will take you to the that would take you to the left lobe of the liver, basically segment 2 and 3. And other thing before I the liver, these liver segments are divided either by the hepatic veins or the portal vein and its branches. Main thing is you need to remember the left hepatic vein, mid hepatic vein, and the right hepatic vein. These are going to tell you from the stomach about the lobes of the liver, and from the duodenal bulb, on the other hand, we're going to mostly depend on the portal vein branches to see right anterior and the right posterior. So the way earlier we talked about, you go to the opposite wall of the stomach, your liver will come into view. Just get that liver into view, and that the first you're going to see a vein in there. This is the left hepatic vein, and one of the reasons it is a vein, there are two ways you can confirm that. One is if you look at the walls of it, they are not hyperechogenic. The portal vein walls will be hyperechogenic. Second thing what you can do is you can do a power flow on that. If you do a power flow on that, you will see, isko on kar do zara, haan ji. It's a undulant, it's like a multiphasic flow. Hepatic vein is going to have a biphasic flow, not a singular phase. Portal vein, I'll show that, is going to be just a flat, thick line. Arterial, you know that how it's a pulsating flow, but here common hepatic is going to have a biphasic. You see that nice, very nice biphasic flow there. So definitely on the hepatic vein, and this is the left hepatic vein. The segment above this left hepatic vein is segment 2. Segment below that is segment 3. So if we are talking about like a transgastric approach or rendezvous, what do we do that? If you have to do a rendezvous, you probably want to find an area of ductal dilation in segment 2. If you have to do a hepatogastrostomy, then segment 3. Reason for that is the segment 2 is very close to the GE junction, and if you have to do rendezvous, your needle would be straight going into the segment 2 of the liver, and your wire will be also trajectory would be straight downwards. If you have to put a stent for the hepatogastrostomy, the segment 3 is a little bit downwards towards the cardia and a little further towards the body, proximal body, and if you put a stent in there, it faces downward, so the bile flow goes downwards into the stomach. So that's all. These are a few things you can keep in your mind when doing these interventional liver drainages. So here we दोबारा उसको ले जाओ वापस. Okay. So here you see the segment 2 above that left hepatic vein, segment 3 below that. If I bring the scope just like a very little back and I start rotating to the right, I don't see that, until this is a, keep in mind this is a big liver by the way, so it's not giving that much penetration, but I pulled the scope back a little bit and started rotating to the right. When I did that, I come to this bunch of a big vessel right there in the center. This big vessel is the left portal vein, okay? And this left portal vein right here, it has this white band right here. You see this white band? This is ligamentum venosum, and the segment above that is the caudate lobe, okay? And this is the portal vein, and if I push a little bit in, I may be able to see the ligamentum teres. It's a little bit
difficult again because of being a fatty liver, but this is a ligamentum teres right here. So segment caudate lobe was above right here, above that ligamentum teres. Now when I pulled it back, your segment 3 went up right here. So this is really the best position to approach segment 3. Segment 2 was a little bit deeper. Segment 3, I have to pull it back. The segment above this portal vein is segment 3. On the right side was segment caudate lobe or segment 1. And the segment below the portal vein is segment 4. And this is segment 4, a part of the segment 4 which is close to the transducer on the right side is segment 4A, and you go further deep, that would be a segment B. From here, I will keep rotating, pull the scope back and keep rotating a little bit further to the right. So this would be a mid-hepatic vein. You see, it's a very nice same diameter vein throughout from the origin as it traverses through the liver. So segment 4 is above that mid-hepatic vein. This is segment 4A. On this side is going to be segment 4B. And the segment below this vein is a segment 8 of the liver. Okay, I can follow this towards the IVC, and when I come close to the IVC, I'm going to see one more bigger, yeah, that's a IVC, you see that? And then I see another vein right here, which has a bigger trunk, but it tapers down as it further traverses through the liver. So that is the right hepatic vein. Segment above that, segment 8, segment below that, segment 7. So these are the segments you are able to see from the liver. So these are very nice, like even, you see a very nice actually, this is like a big trunk, tapers down there, and segment 7 here, segment 8 there. If I advance the scope a little bit, then you see the mid-hepatic vein right here, segment 8 here, segment 4 there. If I gently advance further, I see the portal vein, and this segment above the ligamentum venosum would be segment caudate lobe. On this side is going to be segment 3. So this is how you see the liver from the stomach. Duodenum, right lobe of the liver is much easier actually to find that, and those segments, and I'll show you in just a second. For that, the only thing really you need to find is your portal vein. So if I put a Doppler here, you see the portal vein right there. From portal vein, now you need to follow that portal vein towards the liver. When you follow that, I'm right at the liver hilum right now, okay? So this is a portal vein right here, a branch going downwards. That's the left portal vein. We already saw that. I'm not going to spend my time on that. This is the right portal vein, which is going to go that way. You follow the right portal vein. Once you follow the right portal vein, you see that right here, it divides into two major ones. One goes this way, other goes that way. This is right anterior, this is right posterior. Segment above the right anterior, segment 5, all that segment area is segment 5, this is segment 8, this is segment 6, this is segment 7. Okay. So that's how you can determine, pretty much see all these. You may, a majority of the liver you can determine, see all that. This is a very nice actually view from here. In spite of liver being big, we still are able to clearly see the complete division of right portal vein into right posterior, right anterior, segment 5, segment 8, segment 6, segment 7.
Khalid, that was very well demonstrated. Especially, I thought it's the other way around. Left is easier, but you made the right look very easy as well.
Right is much easier. Left you get confused sometimes because there are branches there, but left hepatic vein easy to find. Mid hepatic vein sometimes give you a confusion because there are different branches coming out, and also left and mid hepatic vein sometimes have a same origin. Actually 70% of the time they enter into the IVC at the same place, and they connect together before they enter. So that sometimes could be a confusing as well. And then different branches go around. But mid-hepatic vein throughout the course is the same diameter. So that's the way to find figure that out.
Can we just ask you to just go through the lobes on the right again? I mean, just from the branching of the left.
Absolutely. So I'm going to come back. I will go into the duodenal bulb. Same way, like we just got to find our portal vein. You see the portal vein? I will rotate my scope to the left to go towards the liver hilum. That's the liver hilum. You see the left portal vein, right portal vein. Right is close to the transducer. I rotate my scope further to the anti-clockwise, big wheel towards me, and now I'm in the right liver. So right, I'm in the right liver, and then you see that.
There you see the branching very nicely.
Branching. So the one which is going on the right side is right posterior. The one which is going on the left side is right anterior.
Wow.
So all that segment above that branch, where the arrow is segment 5, below that is segment 8. In this case, if I go to the right, the segment above this branch is segment 6, and below that is segment 7. If you are in the second part of the duodenum, you see the right kidney. The segment which touches the right kidney is segment 6 anyway, but that is from the other side you are looking at.
Okay.
That. Okay?
Excellent. Khalid, thank you.
Anything else?
No, that was excellent. Thank you very much.
Yeah. Thank
Any
you.
questions? Anybody?
आपका लिवर पूरा लिवर देख लिया हमने